We are a truly UK-wide partnership. We've got partnerships of government and academia in all 4 UK nations, and the Office for National Statistics is our major data infrastructure partner. So we have funded the development and enhancement and improvement of the ONS Secure Research Service since 2018. Which is really it's expanded considerably over that time, and is now accessed by many thousands of researchers across the UK. And we also have the SafePod network. So some data owners insist on secure room access, if you like, rather than just remote access via home or organisation. And for those data owners, we've got this network of SafePods right across the UK as well, that largely based in UK university libraries, but we've got a lot of big plans to scale up that to provide sort of small secure rooms within those settings as well. So if you go into the next slide. So when I talk about administrative data, I'm talking about everything that government services are running. So it's everything from education system, health system, courts system, and earnings and employment system, so benefits and income. And we also use census data as well, because that is an incredibly useful linkage data set, because that has things like self-reported ethnicity in it, which is a really, really valuable variable to have, but which in many other settings you do not get good ethnicity data, and it's not self-reported. So yeah, we work with a lot of health data, but in the context that we see the real value in using health data, not just in linking it to other health data, but other administrative data sets as well. And yeah, our work obviously is really, really cross-cutting because of this data linkage that we do across departmental data sets. And so inevitably our work is sort of lends itself to supporting all 5 UK government missions, as well as the devolved government's priorities as well. If you go to the next slide. So why is this difficult? Many of you with long memories will remember that there have been previous attempts to unlock the research value of this kind of data. And there was a previous ESRC investment actually before ADI UK called the Admin Data Research Network. And that did have some real successes in the devolved governments in opening up access to this type of data, but it fundamentally didn't work in their engagement with the UK government departments. And essentially, it was no fault of the people involved. It was just that the model was wrong, and we needed a permissive legal gateway for all UK government data owners to be able to use, rather than relying piecemeal on the Education Act or HMRC tax legislation, because that would only ever allow access for very niche type of projects. So we've got the Digital Economy Act now that was passed in 2017, and that gives permissive legal gateway for this type of research. And it comes with several caveats, which I personally think are really, really helpful, because it balances out the kind of trust that the data owner has to have that the system is robust and secure, but also allows researchers to get access to a huge wealth of data. And so those caveats are things like the data has to be accessed through a portal access through a Digital Economy Act, a trusted research environment, and the research has to be in the public good, and it has to be de-identified. So no personal identifiers can be shared with researchers. And yeah, this is difficult also because we have devolved government in the UK, and so the data follows the devolution of powers essentially. So Scotland has always had its own law system, and it's completely different to that of Northern Ireland, England and Wales. Health data again is divided 4 ways, as is education data, and this is why it has to be a truly UK-wide programme, and why it's never going to work expecting all of these data owners to submit data to just one trusted research environment, because we actually see it as a strength of our model that the trusted research environments are based in the jurisdictions that the data is often held, because they can build that trustworthiness with the data owners. You go to the next slide. So yeah, this is a really whistle-stop tour, and I'm very happy to have any further conversations about it afterwards with anybody. But yeah, essentially, we started in 2018. We're now in 2025. We've got really good, solid evidence that we've changed the system essentially for how researchers access this kind of data. And researchers might not appreciate always that this kind of data sharing is incredibly difficult for the civil service to do within the civil service as well. And so we provided that access route for civil servants to be able to analyse each other's data as well, because that wasn't in place within the civil service previously. And we are allowed to fund government departments if it's a budget issue or capacity issue that they've not been able to take this work forward. And it's through investments in Ministry of Justice in the Data First programme that we've been able to revolutionise access to that, all the courts data for England and Wales, and that's all now accessible to researchers both in the ONS Secure Research Service and the SAIL Data Bank in Wales, because of course MOJ cover both England and Wales. And it also helps because we've got one message to sell to departments, ministers, academics and the public about how administrative data is shared, which helps build trust right across the system. And that's been incredibly valuable in terms of building the trustworthiness with data owners, without which we would have no programme, literally. And yeah, I've explained why the Digital Economy Act has been so important to us as well, and why we've been able to make so much good progress on this ever since that came into was enacted. If you go on to the next slide. So yeah, just to talk about some of the incredible data linkages we've facilitated. We've got the eChild data set, which is linking a huge amount of information about education outcomes to hospital episode statistics data. And it really fundamental things, because this is an England-wide data linkage. It's not a survey. You have incredible power of that data. So, for example, researchers at UCL were able to show that there are differences in attainment between children born technically at parity between those born at 38 weeks or 42 weeks compared to those born at 40 weeks. And this is a measurable difference throughout primary school. And we wouldn't have known that without access to that data. And the eChild team at UCL have an incredible website where they publish the details of all their research outputs, and that data, this data is now accessible to researchers through the ONS Secure Research Service. And since it was opened up sort of towards the end of last year, we've now got over 50 research proposals going through that have either got access to the data or are going through the approvals process now, which is absolutely brilliant. If you go on to the next slide. So yeah, and this is just to show that we really want this incredible research linked asset to be evolving over time. And one of those sort of evolutions, if you like, is that you can now analyze siblings through this linkage as well. So not just the child that might have the health condition that's having its education impaired because of that health condition, but you can look at the children, the siblings of those children as well, which is incredibly important because it allows that cross-sectional type of analysis. And anecdotally, we know that siblings of children with serious health conditions don't reach their full potential either, and this is an area that we should really be researching more, and it's all possible through the eChild data set. If you go on to the next slide. So other really incredible work that's been done within the SAIL data bank as a result of being able to link health data to a wide range of administrative data is looking at women who are at risk of domestic abuse, and looking back through their lives and seeing, could these people have been found earlier so that you can avoid that really awful outcome in the future, and for people in similar situations. And sure enough, the short story is there are lots of clues in that administrative data that tell you whether somebody is high risk or not, which is incredibly valuable. And as I'm sure we can all appreciate, just seeing somebody through the court systems or through police and justice systems who's actually got, sort of, who's seriously at risk and potentially has health issues as well. Those systems are not good at talking to each other, but if we can link that administrative data and get that research out there, then we've got the potential to influence policy change as well. If you go on to the next slide. So again, this is a really good example of a data linkage that intersects between sort of health and wider research in Scotland. And again, one of the beauties of administrative data, because it covers a whole health population, the whole population, you're able to drill down to analyze the impacts of various things on really quite disadvantaged communities that don't generally turn up in survey data. And we've done a lot of research across the UK on looked after children and how their life chances are impaired because of that experience, if you like. And we recently published a report a couple of weeks ago with Nat Sen, really trying to highlight these issues. And we've had a lot of engagement in this, but it's an example of a data set where we can facilitate this kind of research now. And there's similar data sets in all 4 UK nations now. If you go on to the next slide. And again, this is an infographic of some of the outputs from that UK-wide evaluation. So thinking about the differences in education outcomes from care experienced children, 25% of care experienced children have never been in employment or education, compared to 4% of school leavers. And that's quite a stark difference when you think about, the impact of that. If you can't get into education or employment after school, how are your life chances impact from there on? And yeah, it also highlighted differences in sort of the organisation of care services across the UK. So Scotland is sort of really big on kinship care, and those kids do have better outcomes than kind of institutionalised care. Although it's still not perfect, it still could be better, and really getting governments to think about that. When these kids, they're generally not in care because of anything they've done. It's the people and the processes and the systems around them. And if government is making that decision to intervene and take responsibility for those children, then as a society, really considering what their outcomes are at the moment compared to other children, I think is really important, and is something that we can now do. You've gone to the next slide. And yeah, this is some really interesting work that was done in Scotland with Police Scotland and researchers at Edinburgh, led by Susan McVie. And it was looking at who the police were fining during various lockdowns, and whether there were certain characteristics of those people that were being fined that needed to be looked into. And sure enough, it was very skewed towards people with an underlying drug addiction condition or alcohol condition or mental health condition. So the question then sort of, and Susan worked really, really closely with the police on this because they didn't want to be victimizing people who were potentially, that was an unmet need during the pandemic when access to services was so stretched, and really sort of pushed forward much closer working relationships between health services and police. If you go on to the next slide. Yeah, and I really like this example again, using linked administrative data. You will remember that the Scottish Government brought in a minimum price per unit of alcohol, and it was deeply unpopular at the time, but they really felt that they had to do quite a major intervention to try and reduce the alcohol-related death rate in Scotland, which is incredibly high. And a few years after they brought in this, researchers that we funded did an evaluation of that policy to see if it was working, and it reduces alcohol related deaths quite considerably. And off the back of that evidence, the Scottish Government said that they were quite happy to continue with that policy, which is incredibly valuable, having that evidence to make your decision on, rather than having to make it in the absence of sort of evidence like this. If you go on to the next slide. Yeah, and other work that we've been facilitating, those of you who've had anything to do with sort of palliative care service structures over the years will know that historically palliative care services centered around people who were dying of cancer, and included experts, nurses and doctors to support those people to die at home. But what happened in the pandemic, certainly in Scotland, there was quite a considerable increase in the percentage of people dying at home. And you could argue, well, maybe that's not that surprising when access to services was so poor, but that, and the risk of COVID, obviously, but that has never gone down. And that has, real implications for service design, because if you've got people dying at home from a whole load of other conditions apart from cancer, then that workforce need to be trained up to be able to support those people to so that they have the best care at the end of life as possible. And on a more positive note, we've also facilitated research being done into whether access to cycle paths, cycle networks, improves health, and sure enough it does. And yeah, really, really interesting and innovative work that you can do at a kind of scale that would just not have been possible before. If you go on. And obviously underpinning everything we do is really, really good public engagement. So in each one of our 4 UK-wide partnerships, we embed public engagement into the decision making of how we take data linkages forward and individual research projects, but we also do a lot to try and communicate better to the public about what we're doing, because we feel like we've got a really good story to tell. There's a lot of public good research that is being facilitated from the use of this data, but we also absolutely recognise that we have to be going above and beyond what we need to do lawfully to provide researchers with access to this data, because we have to maintain that social license with the public to be able to do it as well. Because if there's a public backlash about this because we haven't been explaining it, we haven't been engaging with the public, then yeah, it could shut down the whole program. So absolutely, public engagement is front and center of everything we do, and rightly so. If you go on to the next slide. Yeah, so I wanted to finish with this slide because I know we haven't done everything that we need to do on this, and there's so much more we could do. And this is a slide, the middle picture, nobody will know what that mill is, but it's Acre Mill in Hebden Bridge. And after the war, it was built as an asbestos factory. And this is where I grew up. My mum was a GP in Hebden Bridge, and she had a lot of patients who used to work at the mill who died really, really nasty deaths of asbestosis and mesothelioma. And it took decades and decades for Cape International, that ran this factory, to acknowledge and take responsibility for their deaths. And it's a sort of a really kind of neat example of why previously, historically, this was so difficult. And this factory didn't shut down until 1979. And you think today how, accepted it is that asbestos is bad for health, and yet they were allowed to sort of keep going for so long. But if you think about that, if you only had access to the medical data and even really amazing genetic data, you would not be able to track back to find out why these people were dying, what was the sort of linking factor of all these people. And it's occupation, and it's understanding where they worked, how they worked, and what kind of family systems they were in, and location as well. That's all administrative data, and that really drives me forward. That this is the kind of research that we have to be able to facilitate in the future. And off the back of that, we are partners in Cancer Research UK's CD3 programme that's systematically looking at, if you've got a cancer diagnosis, can you track back through people's lives and work out, where are the signals, what are the things that we should be looking for, so that people get cancers detected earlier, and the treatment's better. And I think that's everything from me.
I think you've got a couple more.
Oh, sorry, carry on. Oh, yes. How could I forget? So we are a programme, and we're currently going through the process of applying for securing longer term funding. And as part of this, we had to commission an external interim evaluation of our current phase of our programme. And the results were really good. So for every £1 spent on ADI UK as a programme, there is over £5 of benefits back. And yeah, and I stress this was external. This is not us saying this. The report highlighted our contribution to, really breaking down a lot of sort of barriers about the system and how it works and how researchers get access to this data. So yeah, finish on a good note. So I think the last slide is my very last one.
Yeah, that's just saying it's
excellent,
really
yes.
Good.
Thank you.
Yeah, thank you very much, Emma. Didn't want to miss on those last couple of ones, because that's really, really important. Okay, thanks very much for that sort of initial presentation, which gives a wonderful overview of the wonderful stuff that's being done. So we now move straight on to our second speaker, which is Dave Clark, who's looking at data linkage in Scotland. So over to you, Dave.
Thanks very much. So yeah, I'm a principal information analyst within Public Health Scotland IDRIS team. So I'm going to talk about data linkage in Scotland. It's an area I've been involved in for best part of 25 years now, so it'll be a little bit of a history lesson as well as the current situation. Next slide, please. So we were formed in April 2020 with a mission to address the public health challenges of the country. And obviously it was a bit of a baptism of fire given the specific public health challenge that emerged around that time. We have around 1,300 people working for us, about 500 in the area of statistics and data. Most of those working with stats came from the old Information Services Division of the NHS in Scotland, ISD Scotland. Our team IDRIS, they were formed in 2012 or 13 in ISD. They themselves emerged from the old medical record linkage team, which I'll talk about in a little minute. At that time, there was less than 20 IDRIS staff. That's now grown to over 40, so more than doubled in size. We've got an army of research coordinators and analysts and other staff groups. So the research coordinators helped researchers navigate what data they need for their studies, help them get through the permissions process, get access to the data, provide that access in a secure environment. Next slide, please. So we've actually been doing it for record linkage for a very long time. It was outlined in the 60s, late 60s, by a director of our predecessor organisation, Michael Heisman. And the probabilistic linkage methods were built on the Newcomb principles that were later formalised by Fell and J. Sunter. And we actually borrowed very heavily from the Oxford record linkage system, which started off in the 60s, I think. We've been carrying out epidemiological linkage studies since the 1970s, and our dedicated record linkage team in ISD was formed in the 1980s. And they would conduct linkages against, and they would carry out linked data analysis on these productionized linkages, which the flagship one was the hospital admissions linked with cancers and deaths. This was updated on a monthly basis. And then we had another one with maternity and neonatal data in there as well. After EDRIS was formed, our trusted third party, where we do cross-sectoral linkage, National Records of Scotland, the NRS indexing team, and I was seconded there for a couple of years to help setting up their processes in 2015. Next slide, please. So we have been doing this a long time, and in truth, the probabilistic methods haven't changed an awful lot over such a long period of time. So it is important that we monitor the quality of the linkage, and we've done a few quality assurance exercises around that. This was one led by Professor James Boyd from the Centre of Data Linkage in Australia. It was back in 2011, but he evaluated about 15 different software packages, linkage packages, and/or data linkage units from around the world. And it was pleasing that in terms of the F measure, which is an overall linkage quality metric, which sort of takes the balance between precision and the sensitivity of the linkage process, we were ranking joint highest across those 15 units. So that was really pleasing. We've done some internal quality assurance as well, this one in 2015. So we're always reporting much less than 1% false positive, false negative rates. Next slide, please. And yeah, this was just an updated one in 2019, which we also brought in at National Records of Scotland, our third party. They've got different probabilistic methods. They've also a different population spine that they use for indexing. So again, they were reporting very good, strong results. So we were pleased about that. Next slide, please. In terms of the data that we hold, so we literally can go from before the cradle, from the maternity information and the statutory birth registrations, and then go all the way through to end-of-life care and then death. So I think the yellow highlighted ones in this slide, these are sort of newer ones that have come on board. We've got a cleaned up and analyst-friendly Scottish linked pregnancy and birth data set, so that's a linked data set. And we've got hospital prescriptions now. That's built on the community prescribing that we've held a long time. The diabetes registries have been around a long time in Scotland, but it's now been brought into Public Health Scotland, so we'll get direct access to that data. And then the big one at the end there is Scottish medical imaging, which we'll see a little bit about at the end. We've got pretty much 100% coverage across most of these data sets, and they can be linked together using our personal ID number in the health service called the CAI number. We'll see a bit more about CAI. Next slide, please. So this is what the data linkage landscape in Scotland currently looks like. So if you're a researcher, you want to access linked data, you'll probably come to one of these rectangular boxes in the middle here. So our one, the National Safe Haven, that's run by us. It's operated on our behalf by EPCC, the Edinburgh Parallel Computing Centre. They're part of University of Edinburgh. And so they maintain it and they develop the safe haven on our behalf. The National Records of Scotland, they actually sit outside that box, but they have a key role in making sure that any data that's deposited in the safe haven is pseudonymised, de-identified. The right-hand side block, so if you're looking for more local data, you could go to one of the 4 regional safe havens in Scotland. So there's one in Glasgow, the Health Informatics Centres in Dundee, Data Lock cover Edinburgh and the Lothians, and the Grampian Safe Haven in Aberdeen's called Dash. They can also provide more granular level data, so richer sort of clinical information, such as laboratory data and so forth. So round about that, we've got all these partners that we work with. So we've heard from ADR UK. It was heartening to hear these sort of positive outputs that they're produced in Scotland. We work very closely with the Scottish Centre for Administrative Data Research. We resource dedicated research coordinators to support the SCADR studies. Work with most of the academic institutions in Scotland. On the left there, each Health Data Research UK, they fulfil a similar role to ADR UK, but more specifically with health data. DARE UK are the Trusted Research Environment Network across the UK, which we're part of that network. In the middle there is Research Data Scotland. Can you move to the next slide, please? So RDS were formed in 2021. Their mission, to make it faster and simpler for researchers to access public sector data for research. Next slide. And so their aims and goals are kind of familiar to other partners, but I think crucially that bottom bullet point there, they provide the leadership and the coordination within the Scottish data landscape. They really provide the leverage to help these other partners to fulfil their aims. A good case in point is it's called the Researcher Access Service that they helped set up alongside Idris about a year ago. So this creates a digital journey for researchers from their point of access when they first inquire about a new study all the way through. They can monitor progress on this digital platform and hopefully get that data a lot quicker. There's a much simpler permissions process as long as the data that they're requesting is contained within this platform. We've got 9 sort of core health data sets in there at the moment, and we're hoping to build on that in the future. So that's been a really big win for RDS and Idris working in collaboration. Next slide, please. So just a little bit more about our trusted research environment, the Scottish National Safe Haven. The researchers who come in will access the data through our analytical environment. And most of the access is remote access via the researcher's own academic institutional network. But we do have an agreement with the SafePod network. Idris team are currently homeless at the moment, so we don't have the physical safe settings of our own, but we hope to reinstate them once we've got our new home. So other parts of the safe haven are the secure administrative data holdings, where we hold data sets such as the ADR Scotland holdings, which I'll talk about these data sets in a minute. We also hold the Public Health Scotland data, and there's imaging data, which is a really big one for us. The Project Innovation Zone, so that's where researchers want to do something a bit more out of the ordinary. If they need high-powered computing, if they're going to be doing some sort of AI, machine learning type work, using perhaps their own software that they're bringing into the safe haven that can be containerized from the rest of the trusted research environment. Next slide, I think, please. In terms of numbers then, we support over 200 projects currently in the National Safe Haven. We get about 300 new inquiries each year. Our research coordinators helped submit 100 new applications to the Public Benefit and Privacy Panel. So that's the panel who scrutinise and approve on behalf of the NHS in Scotland access to that data. And there's about over 200 amendment requests to existing approved applications that we process each year as well. Any outputs that need taken out of the safe haven, they need to be scrutinised for disclosure risks. There's about 600 of these requests every year. In the secure holdings, we've got over 40 data collections, including linked multiple data sets. The example here is ISRIC and PHOSP. I think these are COVID-related data sets which used to support a number of COVID research projects. And we've got about 600 active users at any point in time in the research environment. And we offer the standard analytical packages, R, Stata, SAS, and so forth. And as mentioned, there's high-powered capabilities for machine learning and this container execution service for more technical, advanced users. Next slide, please. So this is the list of ADR Scotland datasets that are currently ingested and available for researchers to use at the moment. It's mostly data from the Scottish Government Education Analytical Services, such as the Pupil Census or qualifications. We also have some agricultural data in there, the EU Farm Structure Survey, rural payments data, and there's actually data coming from Ministry of Defence at the moment. The service leavers database is currently being ingested as we speak. Next slide, please. This slide is just to show that it's not a totally straightforward process to bring in this data and then link it for research. So what you typically have for a single data set, it might be split in 3 separate ways. So obviously the personal identifiers have to go to our trusted third party at NRS in the indexing team. So the personal identifiers, such as names, if we have them, will go there to match against the spine. But even the data that's going to be available to researchers has to be split in this.
Oops, sorry.
That's all right. So there's a main storage area where the bulk of the data will go, and then there's a demographic area which might contain the more sort of personal, more sensitive stuff like age, sex, postcode, ethnicity, and so forth. So the crucial thing is that they are separate areas. Separate EPC staff have access to them, and they've got separate dataset keys. So you can imagine that makes it quite not straightforward to bring that together. So they have to be extracted and deposited in a linkage area, and then we get the keys from NRS in order to link these back together again. So we're looking to do a more to come up with a more simpler environment infrastructure, so possibly more akin to what they have in Wales with the SAIL data bank, but discussion's still ongoing in that regard. Next slide, please. So curl, this is one of my projects, which is why I want to talk about it. It stands for CAI UPRN Residential Linkage, so an acronym, but it's basically about being able to link people with the place where they lived. So we did that 2020 to help support COVID activity. So breaking down these acronyms, CAI stands for Community Health Index. We use it as our population spine for linking health data. The UPRN is a unique property reference number, comes from the Ordnance Survey, and every address in the UK has a UPRN. And then we've developed the work we did in 2020 to look at the longitudinal address history that we've got in CAI, so we can go back about 25 years, and any changes in address for patients on CAI, we can we've tried to seed with a UPRN. We can get up to about 95% of the addresses on CAI seeded with a UPRN. Next slide, please. Just a little bit more about CAI. So the CAI, everybody in Scotland has their own 10-digit unique ID number called the CAI number. So that's anybody who's been registered with a general practice since about the late 1980s. The KI numbers now embedded across most of the NHS Scotland data sets, so we can link easily using health data, but we can link beyond that because the KI number is also attached to the National Records of Scotland indexing spine, our trusted third party. And as I said, we've got the KI address history tables go back to 2000, which we've matched to UPRN. Next slide, please. And this is just to give a little example of what we could do with curl. So on the left-hand side, that's stuff we've been doing for a number of years at a person level. In the green ellipse, we could link health data, for example, prescribing within patients using the KI number, but we could link beyond that to data in the pink ellipse at the bottom there, such as census data, education data, anything that could be matched to that trusted third-party indexing spine, we can then link across to health. But crucially, what in the middle there, the curl address history file, we've now got the KI number with a link against the UPRN for every change in address with a start date and an end date. We can link that UPRN across to anything on the right-hand side. It's anything at a property level, such as energy efficiency, such as council tax bands and so forth. So we begin to get an idea of what's possible. Excuse me. Next slide, please. So final thing we're going to talk about is the Scottish medical imaging, and that's basically it's all the images that have been collected within the health service in Scotland between 2010 and 2018. So it's a huge collection. It's about 1.5 petabytes of data, or 1.5 million gigabytes. And as Dear UK and the Landscape Review said, it's unprecedented in the UK, Europe, and perhaps beyond. So it's a really rich resource. We've tried to reconnect it with the national tax system. That's a picture archiving collection system. So just to keep that updated. The next slide, please. And this is basically what you get. So all these images are available in the Safe Haven, but probably most studies actually don't need the images themselves, but what we have is the rich clinical metadata tags that sit behind these images to be cleaned up, made research ready. They're linkable to any other data set via KI, to health and beyond. There's a lot of AI and machine learning work already getting undertaken on this rich resource, and some impressive outputs being delivered on that. So it's something we're really proud of within the IDRIS team. And then next and nearly final slide, I think this is just some web links if you want to find out a bit more about some of the things we've been talking about, with contact details for IDRIS and Research Data Scotland up there as well. And then final slide, just to say thank you very much, and these are my contact details should you wish to get in touch after this meeting. Thank you.
Thanks very much, Dave. Very impressive, all of that. And just a reminder to everybody that the slides will be on Stats User Network, so you can look at them, follow all those links, look at them in more detail afterwards. And also, if you've got any questions or comments, please share them on chat, and we'll come to them at the end of all the presentations. So I'll now move on to our final presentation, taking a slightly different view on it, looking at practical applications. And Les Mayhew, over to you, Les.
Hi, thanks very much. I'm going to talk about stages in the use of administrative data, the units of analysis, which are primarily households, UPRNs, and individuals, or both. And I'm going to talk from selected applications. I'm drawing on a huge back catalogue of lasting about 25 years. So I'm going to be a bit selective, and hopefully these will be of interest. I would say that all of the examples I'm going to give have been very influential in terms of decision making and policy. Mostly they are aimed at the local area and the local in character, hence this logo to the bottom right, which is the umbrella organisation or company we operated on, called Mayhew Harper Associates, and NKM stands for Neighbourhood Knowledge Management. So the examples I'm going to draw on are households and people, or combining households with surveys of household expenditure, ethnicity, religion and income, the impact of proximity of access on service take-up, health costs, lifestyle determinants, and something I've been working on recently as part of a government task force, which I was invited to work on it. It's called age-friendly areas, and this is a response basically to our rapidly aging population, and you'll see more of that later. So since we've been doing this, the data landscape has changed, and we've heard quite a lot about safe havens and so on from the previous speakers, and the access rules to data will become tighter. But I'm not going to focus on us. We work through lots of different iterations of data access and various different rules that were current at the time. So just to say that this is really hugely, but has huge potential in all sorts of ways. And I think by focusing on local level, I'm giving a different perspective to the two previous speakers, which I think is sort of valuable in a way, just to show that there are other ways into this. Who am I? I'm Les Mayhew. I'm a former senior civil servant in DHSS, DSS, the Treasury and the ONS. But for the last 20 years or so, I've been Professor of Statistics at Bayes Business School and Director of Mayhew Harper Associates, which I mentioned earlier. I also have research interests in other areas, especially population aging, as I've already indicated, longevity, retirement, and housing and inequalities. And these feed back and forth into what I'm going to show you today. If you're interested in following up any of the peer review publications that surround this work, you can find me on ResearchGate if you're interested. Next slide, please. Just a few initial words about the limitations of official statistics, which got me into this subject area, and I suppose echo what the previous speakers may have said and found already. Lurking in the background is obviously the safeguards and agreements we put in place for dealing with personal identifiable data, and I can talk about that in the questions Q&A if anyone's interested. Next slide, please. Who are our clients? Well, at this point, I want to name check Jill Harper, with whom I've worked closely for almost 25 years now, and her key skills are data linkage and GIS, and her PhD is informed by the work that we've done over that time. She's the brain behind some software, open source software package called Assign, which basically assigns data to addresses and UPRNs, and it's an incredibly valuable piece of work. The bulk of our clientele were in local government, and you can see this at the in the top of this table on the screen at the moment. We also worked with think tanks and consultancies, and some examples are given there. Central government a few times, especially the Prime Minister's Strategy Unit we worked with on a few things, and so on. Charities, they were quite important to us because they had huge sources of interesting admin data. So, for example, the one there on Whiteley Village is a retirement village in Surrey, which had detailed records going right back to 1916, I think it was, of everybody who ever passed through that. So we had amazing data there. And we've worked with NatSen. And more recently, I've been doing work with the private sector on retirement housing, but we also done work with Specsavers. I'll mention something about that later. The Guardian, who were interested in some of this work, and so on. Academia, there's some examples at the bottom. Typically, our clients were senior level in local authorities. They could be the chief exec, director of housing, social care, children's services, and so on, and also directors of public health. So we had a broad cross section of challenges and projects that we were able to do. Typically, our work was used for commissioning or evaluating services. informing policy and communications also with the public and media at stakeholder events, for example. It's also led directly to the passing of local legislation, especially in the case of private landlord licensing schemes, because of the ability to link private rented accommodation to antisocial behaviour from a variety of sources. Antisocial behaviour here very broadly could include dilapidated properties, it could include unkempt front gardens, fly tipping, criminal damage, noise and so on. So very valuable in that regard, and we had several achievements of helping local authorities get that legislation through and winning over their local populations and electorates. Other impacts we've achieved include radically improved waiting times in accident and emergency in a large teaching hospital, and secondly, referring back to Whiteley Village, which I just mentioned, showing that living in a retirement community can significantly increase lifespan. Next slide, please. This is intended very briefly to show an end-to-end process which shows how we build our data, depending on whether our data units are individuals, addresses, or both. The end product is a de-identified data set, which is then used in a multiplicity of different uses, and some examples of those are listed on the right, and the interim stages show the processes we go through. So for example, we classify households from the basic population data. We then compute or analyze different aspects of each household, including ethnicity, which I think was mentioned earlier by somebody, and then we apply them to the various policy areas that you see on the right. Our sources of data are on the left. That's only a few of them. In recent work, I think 5 years ago, is with Tower Hamlets. We use all sorts of interesting NHS data, inpatients, outpatients, and so on and so forth, and we combined all those together. How do we start on all of this? Well, first of all, I was asked by London Borough of Brent after they found discrepancies between the 2001 census and what they knew or thought to be the case in their own population. It turned out that this was replicated in other London boroughs as well. And it led to questions in Parliament because, frankly, the 2001 census was a bit of a car crash. But we did the same in many other boroughs, including the Olympic boroughs, where our data was used in preparation and for post-game preparation of the Olympics and post-games planning by the GLA. Sometimes the gulf between our population estimates and the official figures in that period to 2011 were really significant. And we were vindicated after the 2011 census, which showed our counts were more accurate than the counts then in use. A key recommendation was that our method was cheaper and could be updated annually and was more flexible with greater granularity. Commentary on our methods was covered in a select committee report back in the time, and that led some changes, including a great commitment from the ONS to use admin data in future. Next slide, please. So what are the types of data linkage and validation? Well, I won't spend too long on this. So the main things are name matching. This is about linking individuals across data sets where you don't have a unique identifier like an NHS number or an NI number or whatever it happens to be. But sometimes name matching is the way to go. But the challenges including matching people with the same names, obviously. So we used a whole range of confirmatory information from various other data sources, such as addresses, dates of birth. So essentially a rule-based process, probably very similar to what other data matchers use. An example is, for example, confirming it's the same person at an address in at least 2 data sets, or if there was more than one address, using the latest address as our confirmatory indicator. Address matching is used to link persons up to addresses and therefore UPRNs, and thus enabling GIS applications and incorporating other data sets. So I guess we've been using UPRNs in our work at least since the early 2000s. Service data are also matched by people and addresses. Typically, the service data that you find in a local authority setting won't have unique identifiers on them, like NI numbers or NHS numbers, so you have to work with other confirmatory type information, as I've indicated already. So we were assignment types there. I'll come to one of them in a moment because I think ethnicity was mentioned earlier. That's a very interesting one which we've been able to crack, I think, in a very useful way, which might have wider applications, and also religion, which was quite interesting. Crime data, antisocial behaviour. Well, I mentioned antisocial behaviour. Things like noise complaints and so on tend to be address-based, so you can build up a picture from that, but some crime data are based on scene of crime and might be 300 meters from an address, or not necessarily the address itself, so that means different handling. It might be proximity to objects such as shops or bus stops, stations, and so on. Next slide. Just to say, I haven't really mentioned how we analyze the data yet, but when you have comprehensive data like this, which is a sort of flat file by address, by person, and it's as 100% as we can make it, it actually makes it simpler to devise tools in terms of how to analyze it. So it meant that we could use basic statistics, informative tabulations, regression, nothing too complicated, and rarely involved complicated procedures, for example, for imputation or filling missing values. So we were very lucky there. In terms of households, we devised our own because it was simplest to do so, and we ended up with a mutually exclusive set of households that could be easily defined and aggregated from the base data. So we had the following. We had, and by the way, it's very useful. I've been using this in other work for forecasting the demand for housing and consequent on the future composition of households in various other studies. So that's one very practical example that has continued, and I've combined it with census data as well, but you don't need to know that here. This eightfold classification consists of family households with 2 adults and kids. Sorry, yeah, 2 adults and kids, doesn't matter how many. It involves type B, single adult children with kids. Type C, older cohabiting couples, at least 2 adults with 1 or more age 65 plus and no children. Type D, older person living alone. Very interesting category that, because older people living alone is can be a very vulnerable group. Type E, 3 generational households. You've got people in that household aged between 0 to 19, 20 to 64 and 65 plus. Not so many of these around these days, and the data reflect that, but another interesting category. Cohabiting adult household, a very large group, and has been increasing because people delaying having children. Type G, adults living alone, another very big and growing category. Then I've got this small category at the end called type H, or other households, and they're called skip generation households. They might have an older person with children, or they might be student households and so on, but they're pretty small in size. Okay, can we go to the next slide, please? This is going to be my first case study, and a common issue we found working at local level in terms of who the users of these data were, was how to combine administrative data with data that are only known to individuals. And data that's only known to individuals is collected through surveys. So what we needed to do was, what we wanted to do was elicit information about spending or attitudinal data, but then combine them with administrative data. In this case, the types of households they lived in, the quantity, the number of those households, which is shown here in the second column, average household size, and other information. So that other information, the administrative data combines to produce the first 5 columns of that data set, and then the survey data is the final 3 columns, spend per head on electricity, gas and groceries. And this turns out to be very interesting because it shows a lot of what you expect. It shows the pressure households may be under if they are living alone, for example, if they're on benefits, and you see this reflected in the spending processes there, how much people spend, and you can also see read into it the economies of cohabitation if you want to. But anyway, that was done for I think it was the London Borough of Newham, and very valuably used as well it was. Okay, that's that slide. Let me move to the next application, please. Thanks. This one, some of you may recognise the shape. It's Tower Hamlets, or actually it says it on the left-hand side. And we've done multiple projects of Tower Hamlets down the years, and this particular one reflected a concern that this borough had the lowest take-up of eye testing in the whole of the country among the 60+ population. Eye testing for that group is free, or at least it was. I assume it still is. And so what we did there was we compared the uptake of eye tests with where older people lived. And where older people lived in the left-hand map is indicated by the black dots, and the eye testing centres are indicated by the blue squares. And you can see many of those eye testing centres were towards the north of the borough, or at least towards the west of the borough. And what you found was that there was a tendency for the ones who were furthest distance not to use the facilities that were available. So those ones with black dots are more than a 10-minute walk from the local nearest eye centre. So we asked the question in conjunction with the people working on this, deciding what to do. How much take-up would improve if eye testing could be done in GP practices operated by a mobile service? This gives a more equitable solution, as is seen on the right, where a vast majority of older households would now be within a 10-minute walkable access to their nearest GP. And indeed, this was the case, because if you show the next slide, please, these columns show the take-up in eye tests consequent of the shifting provision. And basically what we found here was an overall increase in uptake of around 15% due to improved proximity. So this idea has multiple applications across a range of services, advice, drop-in centres, dentists, pharmacists and so on. And we've used it multiple times in various guises. Interestingly, Specsavers now offer a home service, eye testing service in people's homes. So I think we were ahead of the game somewhat there. Next slide, please. This one is about religion. It's an application which addressed an issue between Hackney local authority and the Haredi community, which is an Orthodox Jewish group, about funding services like children's centres and schools. And they both had different estimates of how many there were in this very tight Haredi group, as you might imagine. It's quite a close community. So the problem was nobody quite knew how many Haredi there were and where they lived, leading to divergent views. So in partnership with the community and the council, we used a register of Haredi heads of households, the GP register and other sources to produce precise figures of their number and location. And you can see that in the map to the right where they're located. In fact, the community spills over into a neighbouring borough, where we also were asked to extend the analysis to that population. But this was the first one, and the results were hugely influential. They were used to commission various new services, support schools and other things, and it was used. The data were used for many years afterwards. And I met up with them recently. I think this work was done over 10 years ago. I met up with them recently, and they've still been using it today. So on the left, you can see the breakdown of what we were able to do. Total number of households in the London Borough of Hackney, the percentage on benefits, and then that breaks down into Haredi households and other households. And what you immediately see there, that is the Haredi households are relatively much fewer in number. About 58% of those households were benefit households, and that compares with only 30% in the rest of the population. Anyway, that further breaks down, and you can get from this and other data that we collected a very useful summary of the population and their position in Hackney, which has been very valuable ever since for planning and other purposes. Next slide, please. So ethnicity was mentioned a couple of times by the previous speakers, and it is one of the most difficult things to do, and the census gives only a very broad brush indications. So we had lots of requests in our work in different places how to deal with that gap and count communities more accurately, especially by nationality or ethnicity. And we did this using administrative data. There are other data sources, official administrative data like national insurance numbers and so on, but we didn't go down that route. The route we went down here relies on the school pupil database, and this is very rich in information about nationalities, countries of origin, mother tongue, even dialect. Over 100 different subgroups, I think, we employed in this particular analysis. So through many studies, we collected lots of school data and experimented with it by linking names to ethnicity and country of origin. So in other words, if we knew the name of a school pupil or a person on the GP register, we could identify or at least predict probabilistically what their background was. And this example, as you can see, is for Waltham Forest, and the map to the right there shows, for example, the location of the Asian population, which is obviously a collection of different nationalities. In the table on the left, the table on the left shows the number of categories that we actually considered in this case. So what we did was we assigned a probability of origin to names based on the frequency of occurrences of names within each ethnic group. This was very easy in the case of school-aged children, where the information was precise. But with childless households, we assigned a probability. So extending the probabilistic basis to the whole population was the key to this. We used a 3-tier classification, which is basically the 3 census tiers: white, black, Asian, and other. And then we, in tier 2, we broke these down. For example, black is subdivided into African, Caribbean, and as other, also as per the census. In tier 3, which you see on this slide, we devised our own table like this one, which shows the number of people by country of origin. The granularity is far greater than the census, obviously, and this one also gives information of benefit status and housing tenure, so that you can then look at the income characteristics and support characteristics of people in different ethnic communities. And you can see there's very wide variation if you cast your eye down the benefits column or the social housing column. So on the benefits column, white British only 24.2% of that population, of that 82,396, were in benefit households. The total population is shown at the foot of that column, 247,503 people. And so you can just work down the groups there. They're ranked in terms of size. So Pakistani are the second largest community, Black Caribbean, Indian, Bangladeshi, and so on and so forth. And we even include somewhere in there Gypsy, Roma, and others. Anyway, I don't think I need to sort of go on much more about it, but it had lots of, it was very welcomed by all of us. It had lots of applications, understanding the impact of migration on local services such as housing, translation services, education, just to name a few. Can we go on to the next slide, please? This next example is centered on health costs and wider determinants. The issues were to understand the financial impact on health providers of different health behaviours and morbidities, in this case lifestyle related. And this work was done for the London Borough of Tower Hamlets again. And we did this work for different age groups, 0 to 19, 20 to 64 and over 64, using different risk factor combinations to see how different what are called modifiable risk factors influence the cost of providing hospital services, secondary care costs in this borough. And here's an example of some of the outputs here. So the data were from a very large study which entailed partnerships with the local authority, Queen Mary College, UCL, and the Department of Health itself. And we linked together NHS data, personal clinical records based on the GP register, and then local authority and other sources of data as well, households, benefits, and so on and so forth. So this is just a very small snapshot. In fact, we published our report in 2019, which should be on the Tower Hamlets website. It has 23 case studies in it using administrative data. And this particular one, we were asked the question, how much do risk factors such as pre-existing conditions affect the cost and use of healthcare services? And the application on this slide, we focused on 20 to 64-year-olds, linkable data here including smoking status, presence of diabetes, hypertension and obesity, plus NHS tariff data on the cost per episode or visit. And we use multiple regression to extract the financial impacts of each risk factor in turn, based on average annual inpatient costs. And what you can see in this chart, this graph on the left, you can see that the cost of per annum of treating current or ex-smokers added £237 a year to secondary care costs. Obesity to these are additive, by the way, £225, diabetes £469, and hypertension £382, all on top of a baseline cost of £155. So if you were unfortunate to have all of those lifestyle factors, you were costing the taxpayer and the local health service over £1,400 per year. Anyway, we repeated this using other wider determinants as well, interestingly. So, for example, if you lived in a one-parent household, that had the effect of increasing your annual healthcare costs. And there were other key factors like living in social housing, living on benefits, as you might expect. So these have proved very valuable in actually identifying and targeting groups that sort of cost the system the most and may be needed, where more preventative interventions might be needed. Anyway, make what you will of the results in terms of applications. They have several ways of interpreting and using them, but the message is that unhealthy lifestyles cost the taxpayer. Can we move on now? Next slide, please. Yeah, 3 years ago, I was asked to work on the adequacy of retirement housing, of which there is a very large shortage. By 2040, there are going to be 17 million people aged 65 plus, most of whom will continue to live in mainstream housing. But this all led to a report called the Mayhew Review, Future-Proofing Retirement Living, Easing the Care and Housing Crisis. And this review in turn led to a setting up of the government Older People's Housing Task Force, of which I was a member, and which was published in 2024. Now, it was important to check if older people are connected to communities with walkable access to everything they needed,
Right.
and not everywhere is the same. The issue is that if they live remotely, they might be isolated, and they might call upon public services, social care, and others in greater volume. So the idea of this was to look at or try to rate local areas in terms of their walkable access to everything they might need, and these things could include nearness to a GP, a pharmacy, a dentist, a post office, a shop, a place of worship, and so on and so forth. So as part of that, I developed an algorithm to measure the age friendliness of properties and hence communities, which is linked to multiple administrative data in multiple different ways. The outputs include maps, tables, and analytics, which then have a range of uses. So we're doing work with Stoke-on-Trent, which is using it to engage with stakeholder groups and service providers to provide a sort of strategy going forward. And if anyone's interested tuning into this, we're looking for other partners to develop it further. And so if you're interested, do get in touch. But to give you an example, if we have the next slide, please. This is a map of Stoke. It's a mixed conurbation made up of 6 townships, but with no obvious focus or pattern of land use. The results to the right are pretty high level, but briefly we evaluated access to 5 services: GPs, pharmacies, post offices, dentists, and shops. The red contours you see on the map show concentrations of older people at a point, so we can also compare these with the colour coding on which they sit, and the colour coding basically codes every UPRN in Stoke-on-Trent according to whether they have access to all 5 of those different services within 10-minute walking distance, or whether they have, at the other extreme, no access at all. And we found that something like 41% of all properties have access to 5 of those services, 17% to at least 3, with 5% having no access at all. And we also found, very interestingly, that older people had inferior access to services as well. So that really identified something that quite important that was going on in the area and would need addressing in various different ways. So coming to my last slide now. Next slide, please. Just some conclusions summarizing what I've shown you here. I think probably I'm speaking to the converted here, but administrative data should be used and locked away in filing cabinets. And there's a rich goldmine of data existing at local level, which has been still overlooked, and which clearly from these applications has considerable number of uses. In order to get sort of, I sometimes see 2 communities out there, researchers and decision makers, and the decision makers are not necessarily linked to the research and vice versa. And so I think it's important, we found it important anyway, to get on the same wavelength as decision makers at local levels in order to support this joined up working, because that is a major issue at local level. We also think the applications that I've been showing you today are pretty good fit with the NHS's 10-year strategy, because they're also about prevention, looking for ways in which to improve the health and well-being of local people. And I think one of the prizes that we found is this ability to link health outcomes and wider determinants of health, which can help to inform investment in the health and social care economy. So I think that, you know, as a group, we probably need to focus more attention on the successes of using administrative data so that they can be applied and nationally rather than in one locale at a time. And I also think there is, because I work for OS and I know how it operates, there's a role for local areas to feed linked data into the ONS, which I don't think is happening at the moment, or if it is happening, it's not happening at scale. So thank you very much for listening. I do have a couple of slides which show briefly some sources of accessible documents which give more details on most of these applications that you have been exposed to. So thank you very much.
Thank you very much, Les. That obviously won't run on a bit longer than expected, but there was so much interesting stuff I didn't really want to cut it short. But just to remind people that all the presentations will be on Stats User Network, and all those links and the references that Les put at the end there. So that's the end of the presentations. So we normally have about sort of 5 or 10 minutes for questions. I'm going to run on a little bit longer than past, because just to pick up on some of those. So I know that people have been putting questions in the chat. What I'd like to do, I think, is to just go through. I mean, I'm hoping the speakers have also been looking at the chat so they can see the sort of comments coming in. Just running up to the just picking up a few of those. There are a couple for Emma, so I'd just like to pick those up first, as to whether ADR UK is working alongside the Research Secure Data Environment Network and also data linked to specific study cohorts.
Yeah,
so
I've answered those questions in the chat, Dina, so because I realised we were going to run out of time. But yeah, I'm very happy for people to get in touch if I haven't given complete answers to the questions. But yeah.
So yeah, thanks very much. I can see you've answered quite a lot of those, and this one, the benefit of the chat. What we'll be saying is that actually in the report of the meeting, we will actually put the questions and answers from the chat, and also the speakers have an opportunity to comment afterwards. We send them all the chat comments, so they've got an opportunity to comment later. I mean, is there anything? I mean, looking at what we've got in the chat. Is there anything that the speakers would like to sort of come back on in terms of that, as well as responding in the chat? Emma, obviously you responded on a few. Are there sort of responses that you'd want to sort of pick up on in terms of responding to the queries that people have raised? And so we will share what you've put into the chat.
I can't remember whether my contact details are on the slide, so I'll just share it in the Teams chat now. And I should have said, we've worked really hard across our 4 trusted research environments to create one data catalogue. So there's one place that people can go and search for material. So I'll put my email address into the chat, and I'll put the link to the data catalogue in there as well. Thanks.
That'd be really helpful, yes, as I say, and then we'll post all that afterwards. Dave, I know we haven't given you a chance to sort of come back. Any comments or queries that you'd like to, sort of get some sort of feedback on from what the other speakers have said, or anything that's coming up in the chat?
Not really. I've responded to the one question on synthetic data. We haven't actually done anything with synthetic data with the health data sets yet, but we're being very much led by our partners, Research Data Scotland, again on that. They have produced some census data, and they've spoken, I think they've spoken to public panels, certainly spoke to researchers about the types of synthetic data that they want. And yeah, so there will be synthetic data coming. That was the question that I picked up on for myself. I didn't see any others that were specific for
I mean, I
Scotland.
think it's a question, I mean, probably sort of to you and Emma, is there anything that, I mean, we see these webinars as starting an exchange of ideas and, you know, putting people into contact. And there is an opportunity for that on Stats User Network and also when we get onto Analyst X. So is there anything that you would see that you wanting sort of comments or suggestions or liaison with sort of the wider stats user community? You know, you've obviously got lots of contacts now, but is there something that you would particularly be interested in comments and thoughts on? So Dave first and then Emma.
I think the use cases certainly from Les was given that was certainly very insightful for what they've been doing with their, you know, linking up the sort of the geographical side with the person side, that sort of stuff that we're trying to develop here in Scotland, and it's an amazing piece of work that was sort of there.
So I mean the use cases, yeah. Emma, anything that you want sort of particular people to comment or feedback on from the?
Yeah, so as part of our next investment phase, we don't want to just be creating more and more and more standalone linked data sets for ADR England. We want to be really investing in the ones that researchers are using and make those better, as well as creating some to fill the data gaps, if you like. And so we will be going through a process. The next investment phase, if it all gets approved, doesn't start until the 1st of April 2026. But we will be going through a process to really work out, you know, where we put our money and how we invest and which sort of flagship linked data sets that we invest in and make even better. And that will, of course, include, you know, potentially linking more health data to existing data sets such as the MOJ cross-justice data sets, for example. I can see that would be incredibly useful to understand the health conditions that people are going into the justice system with, because anecdotal evidence suggests there's quite a big link, particularly with mental health conditions. But yeah, that will be a process that will kick off in 2026, assuming that we get the funding secured. And yeah, that's all going fine so far.
Great, thanks. Les, maybe sort of coming back to you at the sort of final thing here. I mean, there weren't any specific questions for you, but obviously it was what covered so many really, really interesting things. People may want to follow up once they kind of look at it with the presentation. Any sort of comments and thoughts that you might want people to feed into you on feedback from the people in the that shared this presentation?
Well, I did speak last, so people have, you know, not had enough time to think about a lot of it. So if anyone wants to write to me to follow up, but just trying to sort of get an overview of what we've heard today. I think our focus has been on local and on impact and on decision making at that sort of level, whereas the other speakers have talked more nationally and aiming at more, I'd say, correct me if I'm wrong, research uses or research communities for their data, and I think somehow it'd be great if they could bring their data closer to the end users, the policy makers here, perhaps by working on projects which have, you know, a clear focus and customer. When I say customer, I mean a policy maker at local level or central level at the end, and that's something I think would be very useful. And I also find it very useful if some of the stuff we're able to do could be linked up to some of your stuff at a national level to sort of broaden the use base of all of administrative data generally. So I think they would be my main points.
Yeah, great. I mean, hopefully, you know, seeing what everyone else is doing, following up after this in terms of making that sort of connection and linkage. I mean, impact and usefulness is really so important in everything that's being done in this time of resource constraints. So,
Yeah,
you know, if you can't
absolutely,
actually
yeah.
make the connections, demonstrate it's making a difference, then, you know, you're really at risk. So, I mean, hopefully that having the combination of the kind of the local and the national side is kind of very, very powerful. So that would be really good. And hopefully,
Yeah,
having
I
made some
agree.
connections here, something that we can
Absolutely, yeah.
follow up
It's been a good
afterwards.
experience, yeah.
Yeah, yeah. Great. Okay. Well, I mean, we can follow up if people want to offer comments afterwards. We will be doing the report, including the Q&A, and we'll give the speakers a chance to make further comments afterwards if they have them, you know, after we close the meeting. But I know, you know, people were told this was going to finish at past and it's over lunchtime, so I don't want to run on too long, but I'd really like to thank all three speakers. It's been absolutely fascinating. There's so much in there, and I know you were trying to gallop through so much in a short period of time, and I'm sure people will want to look at it and mull over it later, so there may be some questions coming later. You know, I found it really fascinating, so thank you to everyone who's participated, all the people on the call as well as the speakers, and do feel free to you know, follow up with us later if you've got any other comments. So thank you very much to the speakers. Thank you much to the organisers, and enjoy the rest of your day and have a good weekend.
Thank you very much.
Thank you very
Bye.
much.